Good afternoon, everyone. This week we are going to be talking about gender identity. For this lecture, I'm going to sort of divide things up into two parts. First, we'll talk a little bit about, gender identity and what exactly that is. What is gender? And then we'll end with a, brief but important overview of what uh, gender affirming care is, what is clearly been in the headlines a lot recently. So I'd like to spend at least a little time considering what exactly that is. Of course, this in general is a sensitive topic in society. So let's all be open to each other's identities and viewpoints on this very important issue that I feel some pressure to sort of shy away from, but that's certainly not the person that I am. I look forward to discussing this topic with you and all of us learning together. Let me see if I can get rid of this little video here. Uh, There, you don't need to see my face on the screen here. So, one big hot button thing that I hear a lot, including from many professors, is that gender is a social construct. So, my response to that is not so fast. Gender can be a social construct depending on one's definition of gender. I've tried not to just drown you in semantics and definitions this term and instead focus more on big picture concepts and mechanisms. But in this case, I think we definitely need to get into some definitions a little bit. So, by definition, according to your textbook at least, a gender role is the collection of behaviors and attitudes that are considered appropriate within a specific culture for each sex. So when somebody says gender is a social construct, I think they mainly are talking about a gender role. A gender role is a social construct, no question about that. The problem is, at least to me, when I think most people say that gender is a social construct, what they're talking about is gender identity rather than a gender role. Now, gender roles certainly can influence gender identity, but there's more to it than that. By definition, the textbook that I'm using right now argues that or defines gender identity as the psychological self-perception of being either male or female. And this would certainly include cultural norms, but is arguably, and I would argue, I mean, very clearly influenced by hormones and neurobiology as well. It is a new field. There isn't a tremendous amount of data, and you can certainly there's a lot of nuance to the data that does exist, and we'll get into a little bit of that as well. But I think especially from the animal literature, there's some pretty clear evidence that things like prenatal hormone exposure can masculinize or feminize the brain, and this can lead to the manifestation of behaviors and influence one's gender identity. Now, one's gender identity and sexual behaviors are again dissociable. There are certainly, and again, primarily from the animal literature on rodents, which are different. We've already gotten into a little bit that the estrous cycle is very different than the menstrual cycle. And especially some of the sexual behaviors in rodents and primates are very different. And then even in different primates, like the bonobos versus the chimpanzees, the one that I keep going back to, Sapolsky has plenty of great examples too. But sexual behavior can vary drastically depending on one's monkey troop or the society they are in even this one country or certainly throughout the world. And this is, of course, going to be very different than what you would see in a rodent. But certainly in rodents, you can see some biological and hormonal influences that can change uh, sexual preference for a specific group of people. So there is likely also some biological, hormonal, neuroendocrine component to sexual identity as well. But that could be dissociated from gender identity, and I mean, is very often dissociable from gender identity. And furthermore, of course, social and cultural and environmental influences can influence sexual identity as well. And I also want to point out that this isn't just things like whether or not your parents painted your room pink or blue. Things like even stress can influence, sexual preference, and sexual behavior. There is quite a bit of evidence that neurobiology and endocrinology interact to influence gender identity. There are, of course, many studies involving or reports, case studies on patients who are not typically XX or XY, but might express XXY or XYY. Such case studies have shown that there could be alterations in gender identity induced at the chromosomal level. There are mixed reports here, of course. And whether or not someone's XX or XY, we now know might not be as important as whether or not one expresses the SRY gene. And there has been some correlational studies that have reported that the expression of the SRY gene can influence one's gender identity. Uh, yes. In addition, we have gone over several examples already in this class in which prenatal hormones appear to organize the brain as being masculine or feminine and influence sexually dimorphic behavior in rodents, at least. There's also been there's that famous RAM study as well, uh, with the homosexual ooze. That is also worth noting. In addition, approximately 50% of XY people who were raised female in the United States due to damaged, deformed, or the presence of a micropenis come to identify as men later in life, suggesting that, even if you're really trying to force the issue, and it's worth pointing out we have some weird social commentary here that in America, having a micro penis would be enough to completely try to shift someone's sexual identity or gender identity. And yeah, that alone I think is worth noting how great of an influence we put on those external genitalia. But as Sapolsky pointed out, even baboons will look for that penis, or very early on. I mean, right after the birth, it is a very ingrained primate behavior, at the very least, to emphasize that secondary external genitalia. Then we have XX people who were born with congenital adrenal hyperplasia, which produce excessive levels of androgen. So this would be a case where someone who is born XX has excessive levels of testosterone, and they're more likely to report confusion with their gender. I will point out that this isn't a huge effect, where you might see currently 1 to 2% of the population reporting confusion or gender dysphoria. This number would go up to about 5 to 6% in the last survey that I assessed of people reporting. And I would say in the 5%, that was severe confusion with gender. Some confusion that number is quite higher. but still, one could argue that if biology were the basis of it all, you would expect a much higher level of gender dysphoria in XX people born with high levels of androgen that would be there throughout not only the activational but also the organizational phase where the neuroendocrine system would theoretically become masculinized or feminized. Um, but a more specific case of congenital adrenal hyperplasia occurs in this interesting case of 5-ARD patients. 5-ARD refers to 5-alpha reductase deficiency. Sapolsky has also brought this up again. Here I'm just sort of surfing in his wake, but it's a very good example and certainly worth emphasizing again. 5-ARD patients often change the gender to male in adolescence with their when their low testosterone levels normalize. Really, it's that they lack the enzyme to convert testosterone to another hormone that's involved with the organization of the masculinization of the neuroendocrine system. Um, and I'll also point out that, from Sapolsky's talk, it sort of seemed that, well, everybody transitions here. It's really about 50%, and there's some nuance that comes in that too. So I will come back to that here and first show you some images of what exactly this looks like. And just so you know, in the next slide, I am going to actually show you some images from a patient that has, uh, uh, from this condition. So that is something you can skip over if you do not want to see, what that actually looks like in a case study. But I will show you the cartoon here, which it should be a little easier to look at. So here you see the development of external genitalia in a patient that is dependent on testosterone there to the left and dihydrotestosterone to the right there. Dihydrotestosterone is, a very important hormone that is only expressed during the early development of uh, uh, the early organization of the endocrine system. And you can see without DHT present, which is what happens if you're lacking this specific enzyme as an XY person, your testes still develop, but they do not descend. The penis does not develop. Instead, you have a more feminine presenting urethra and a blind vaginal pouch develop in the place that where a penis typically would. So again, here is exactly what that would look like in this case study. Again, if you find these pictures disturbing, feel free to skip them. I'm not going to give you any sort of information here that I will quiz you on. This is more just sort of to bring home this point. But at 18 months, in one of these patients, the appearance would be female, even though they are XY. The testes would be fully ascended and hidden, and there's sort of this false vagina that would be present. And eventually, over time, in adolescence, a penis would develop, and the testes would typically descend. But lacking DHT in utero, this XY individual's external genitalia develop as female. However, internally, the gonadal tissue is would be that of a normal male, and its karyotype, which karyotype is a sort of a word, a genetic term for someone's overall chromosomal makeup. So their chromosomal makeup would be 46XY, which historically would have been referred to as a normal male. In utero, DHT is essential for normal male development of external genitalia. So after complete maturation, DHT seems to have no important biological function. It's really only involved in the organizational rather than the activational component. So still here at 8 years, which is uh, I guess about the beginning of onset of America puberty in America now, where puberty is crept up. It's actually occurring younger and younger in the United States for a variety of reasons, possibly. One in which could be, and very relevant for this particular discussion, exposure to hormones and toxins in the environment, in the food that we eat. It's a very controversial theory as to why puberty is occurring earlier here, but it is certainly happening. And the age of 8 would be about the earliest that that would begin to occur. But 8 typically internationally would still be prepubescent. Then at 12 years of age, just before puberty in this individual, which again, 12 would be late stage puberty now in the United States, but just before puberty, prior to the testosterone levels increasing, the phenotype would still appear female. But now, with testosterone surges occurring at puberty, the phenotype would change to male, the voice would deepen, the testes descend, the phallus grows, erection and ejaculation begin to occur, and a male psychosexual orientation tends to develop. And for the rest of their lives, the Guevedosis resemble the other Dominican men in all respects. And again, this is a common to the Dominican Republic. There are other examples, like in Papua New Guinea, amongst other places. But regardless, in the Dominican, these men would all then develop some abnormal secondary sexual characteristics. There could be beard growth, but it's not going to be a full beard. Uh, they typically don't have hairline recession, which is commonly associated with testosterone levels. None has acne, which, would be nice. And that the prostate remains small rather than developing like a large walnut in an average XY person. Um, so, and the most recent surveys that I've read on patients, 5 ARD patients, is that approximately 56 to 63% of those that are raised as girls change their gender to male when they go through puberty, when they get this testosterone surge. So to me, as a biomedical neuroscientist and pharmacologist, I mean, this just screams at me like, wow, this gender identity is being greatly influenced by hormones. Uh, this is very just confirmatory and validating evidence to that sort of biomedical worldview. But even here, I will point out, and I think it's very important to consider all perspectives here, that a social psychologist can and has argued, these are arguments that I've read from social psychologists and their response to these data. They have, and I think these are valid points, argued that maybe this big transition is due, at least in part, to social factors rather than endocrine ones. For example, the 5 ARD patients occur in societies where the transition to female to male is very accepted. In fact, they even have typical names that they call this group of people. Thus, and it's a positive name. It's not they're not being ridiculed or shamed. Thus, maybe it's the social norm that drives this shift versus the hormones themselves. It's also been argued that, especially in these male dominated societies, there are many incentives to transition to male that are confounding the data. If you can only get a good paying job as a male or advance in your career as a male, or I don't know, play sports, maybe you really like soccer and you can only play on the soccer team if you're male. There could be quite a few reasons to transition to male here, in addition to hormones, which is at the very least worth considering. So, how can social influences and one's rearing environment impact gender identity or the influence that gender roles might have on one's gender identity? I think the most likely mechanism is an epigenetic one. So, we've already had a guest speaker refer to some, well, I've already given you assigned content that gets at some of the potential epigenetic mechanisms, including simply just DNA changing its structure to influence, its function and, what proteins would actually be there. Uh, but there are many variables that could influence epigenetic or genetic expression. Again, this isn't just whether or not your parents painted your room pink or blue, or your guardians, I guess I should say, or guardian painted your room. There are many variables here that could include stress, famine, diet exposure, virus exposure, etc. Viruses themselves are poorly understood. There are many theories out there, even blaming viruses for things like schizophrenia. The idea that a virus couldn't change one's or influences one's gender seems a pretty, well, why not? Why not? Certainly, stress, things like famine could impact genetic expression of things like even the SRY gene. Why not? And I'll also point out that the SRY gene also influences the expression of MAO. MAO is an enzyme that breaks down catecholamines in the brain, like dopamine and serotonin. So, depending on one's expression of the SRY gene, you can even have differences in neurodevelopment that could, be involved in sort of this sexually dimorphic uh, neuro neurodevelopment that can and is well documented to occur uh, at times. There are other many epigenetic mechanisms or ways that these sorts of variables can influence translation or transcription as well. These include changing the methylation of the DNA itself, changing the histones, essentially the chromosomes or chromatin will sort of get bound in these tight little balls, and things like HDAC or in how tightly these things are bound in these balls can greatly influence genetic expression and whether or not a protein is actually developed and what that protein would look like. You also have nucleosomes can bounce around or be repositioned. You can have changes in the structure of higher chromatin. You can also have changes in non-coding DNA, which we used to call junk DNA. We no longer do because it turns out it's pretty darn important. We just don't completely understand how yet. And of course, you can have direct changes in DNA and RNA editing. I just want to mention a little bit more about DNA. And, when I was a student, we hadn't yet, when I was in college, one of my majors was biology. And we had not yet completely mapped the genome. I did countless projects on how important mapping the genome was going to be and how influential that was going to be on biomedicine and our understanding of disease and everything else and gender. Yeah, it would just unlock the mystery of life. And it turns out, I would have to say that that has all been a little underwhelming. And one of the big reasons why is that I think we just had this very dogmatic view that RNA leads to DNA leads to protein, and it's always like A, B, C, no matter what. And there's a lot that can happen there along the process of the sort of the molecular dogma of biology. that can lead to altered protein expression further down the line. And that so I guess that's led me to think that really we need to have a better understanding of the proteome rather than the genome to get at some of these differences. And I think that's probably a few decades away, but we're getting closer to completely having a greater understanding of the overall proteome as well. But so yes, DNA to protein translation much more complicated than we used to think when we just had this simple ABC molecular biology dogma. I also want to add that it's possible that social and environmental influences can impact gender identity through alternative mechanisms, but these have not yet been elucidated. I'm a neuroscientist, a reductionist, a materialist. I believe in things that I can see. I struggle personally with some aspects of philosophy. And this is, but I want to say this to open up the floor to more philosophical interpretations in what I'm teaching you here. There could be more. I see the world, I see gender, I see everything through a neuro bias because I'm a neuroscientist. From a neuroscience perspective, all behavior and our conception of a reality originates from the brain. It's possible that this perception is wrong. Some even argue that things like the sun has a consciousness and maybe even a gender. I mean, some really do argue this. I mean, this to a neuroscientist is difficult to comprehend. But as a neuroscientist, I cannot tell you where consciousness comes from in the brain. I also can't tell you where gender comes from in the brain. I can tell you some slight differences of sexual dimorphism that do occur in the brain. And I've done that. I mean, that we covered that 2 weeks ago. But even there, the differences are slight, and you can see greater variability within a sex than between them. So I think that there is a lot that we don't know. Um, you know, that this really comes down to dualism at some level as well. There's the idea that the mind is separate than the brain. Um, as a neuroscientist, this is something I tend to reject. I mean, all of my teachings would reject this. But it's an idea that really goes back to Descartes. The idea that there could be a mind that is influenced by things other than neurons and action potentials and neurotransmitters and hormones. What that is someone that needs an observation and needs a material thing to look at to believe in. There's just nothing there. But that doesn't mean it doesn't exist yet, which is just the big picture concept that I want to convey there. And just saying, there's a lot possibly going on that we just simply do not know about yet. And really, that's about all I have to say in regards to the biology or the lack thereof in determining what gender identity is. Now I'm going to briefly switch to and go over the concept of gender affirming care. Gender affirming care is a hot button subject right now in the political realm and the biomedical realm. Uh, but again, rather than shying away from this, controversial subject, I think it is really it would be a shame. I really almost unethical, I think, not to cover the subject. So gender affirming care is, by definition, a range of social, psychological, behavioral, and medical interventions designed to support and affirm an individual's gender identity when it conflicts with the gender they were assigned at birth. Colorado is one of the yeah, I would say not necessarily few at this point, but certainly not all states are open to protecting and promoting gender affirming care. But Colorado was certainly a leader in this regard. I believe it was the fifth state in the country to pass such legislation. In this case, the first bill was SB 23188. This is a bill that provided protection for those who seek or provide gender affirming care in Colorado. Abortion was also part of this bill. It's my understanding that these concepts are typically coupled together in these sorts of bills legally because they generally involve body autonomy, with the idea that it's my body, I should be able to choose what I would like to do with it. And right, that's why they tend to be lumped together, is my understanding, around just generally promoting individual body autonomy, and uh, trying to make that legally a freedom that one is entitled to. So, what is gender affirming care? And here I think it's very important with these bills and with what people are saying to ask that specific question. What do you mean by gender affirming care specifically? Because there are modalities of legal, social, medical, and surgical components. First, legally, can anybody update their birth certificate or social security card or student ID or driver's license to reflect their self-identified gender, even if it doesn't reflect what a doctor might have put on your initial birth certificate. Here, it's not completely, well, it's quite common, really, that someone might be born with a micro penis or a deformed penis, and that is operated and removed, and the doctors indicate that that is a girl at that point in time in their early medical records. And depending on the state that you're from, you could not change that if you are then one of the 50 or so percent of people that happens to, that then revert back to self-identifying as a male when they hit puberty or later in adulthood. Again, that now you have the social affirming care. This is what I think many people try to promote at CU Denver, amongst other places, by uh, including pronouns. I mean, this is why I include he, him in my title here. It is my way of trying to be, I guess you could say, an ally, or at least understanding, accepting of gender affirming care. But there's more to this than pronouns, of course. People could change their name, and in which case, this happens in the Umbrella Academy, where Vanya, says, I'm now Victor. And, which is really just a cool sort of moment in the gender affirming, care, pop culture, evolution. Everybody's just like, yeah, sure. Hey, Victor, no big deal. Like, so I think that's, I guess, a good sort of fictional written example of this occurring. But clothing style can also, change pretty dramatically there. And yeah, as a parent of young children myself, I can tell you, yeah, I'm almost at my wit's end with clothing and styles, and especially girls' clothing. It I don't know. I never really thought much about it until I brought my kids clothing shopping, and I end up in the boys section a lot just because of the cuts and some of these things, and even at very young ages in the girls section, it's yeah, it's an odd thing. We could have a full conversation on that alone. Now come in the big ones. So I think that this point in time, if we're talking about legally mandating gender affirming care, I think legal and social affirmation seem very benign, relatively speaking, very easy to palate, I would say, even to a detractor of gender affirming care. But I think most of the fights arise when we start talking about medical and surgical interventions. And depending on the bill that you look at, some of these, even are trying to sidestep some of these later components of gender affirming care. But medically, there's a lot that can happen here. GnRH drugs, agonists or antagonists, can be given early on. There's some debate about when this should occur. Simply put, you could call these, one here would be a puberty blocker, where you might want to block one's puberty, as really the onset of it, which could involve puberty blockers going to relatively young people. Then you also have your hormone therapies. This could involve estradiol or testosterone. And typically, most bills that I've looked at so far as of 2024, or where we are, right now, and uh, these tend to be more involved with, or tend to come on more around the age of 16 or 17, that you would see the bill saying that we will protect the doctors from giving a testosterone or estradiol to a patient from out of state if they are 16 or 17. So that's something like the age ranges here, if the bill has even mentioned them, is something that I think is worth paying attention to. I don't really have, I don't think that there's necessarily a right or wrong answer at this point in time. I mean, this is all somewhat experimental. There simply isn't a lot of data and to indicate what happens to people when you give puberty blockers at the age of 11. Um, that but Right. I think that there will be very soon. And the actual hormone therapies of estrogen and testosterone treatment seems to be given out now toward the end of puberty. I do think that, it is sort of a puzzler to me. I mean, like, why wouldn't you start the testosterone or the hormone therapy at the onset of puberty as well? To me, it makes a lot of logical sense from an endocrinology perspective, but that probably has a lot to do more with, alarmists in society. And maybe alarmist is the wrong term. Dissenters, people that dissent from gender affirming care for a variety of reasons or the practice of it. Um, whether or not somebody should have a be able to receive a puberty blocker at the age of 11, or when hormone therapy like estrogen or testosterone treatment should occur, is certainly a matter of debate. And again, I'm not here to tell you the right answer or the wrong answer. I'm just telling you what this is, and some of the trends that are happening right now across the country. Surgical gender affirmation tends to involve, the chest removal, for example, or a breast implant. This can also involve the removal of the penis, or the addition or sort of alteration of, existing, you know, uh, architecture, to resculpt it in either female or male presenting, whether or not you want to be present with a secondary external genitalia, like a penis or a vagina. Obviously, even if baboons look for a secondary sexual external genitalia early on, this is a very important thing to people in general, that their external genitalia match with their gender identity. It seems like the sort of the ultimate conclusion of where you would want to be. However, I mean, not everybody that is transgender wants to go through that final surgical step. I mean, like that's perfectly understandable as well. I mean, that sounds scary and at the very least a lot of work and incredibly expensive. But in addition, these sorts of surgeries are incredibly controversial in the legal bills. I've read several states' bills where they sort of end by addressing the what we call medical intervention here, where they might protect the doctor from giving hormone therapy to a 16-year-old, and then they also specify that age of like they have to be at least 16, which theoretically would be after that neuroendocrine organizational period where the hormone would have the greatest impact, you would think. And then, surgery itself might not be protected in that particular state. These are the devil is in the details with these things. So these are some of the things that I've been looking at when I look at the different state bills that are addressing gender affirming care. Now I'm going to just give you just a couple of stats from this one article that I found interesting called Mental Health and Timing of Gender Affirming Care by Julia Sabrara and colleagues. So Julia and her collaborators, measured uh, and took several self-reports over a number of youths that were at the onset of transitioning. So age of gender incongruence is what you're looking at first here in those blue points. And you're looking at these in what is known as the YPY group and the OPY group. YPY group means that the people, this youth cohort, started to transition or at least recognized and then initiated the process of transitioning before the age of 15. The OPY group would be those that recognized and started transitioning at the age of 15 or later. And by that, I mean like officially, transitioning uh, at the medical level, like where you're actually going to be manipulating hormones. So what you can see here is, simply that there is a big range of when people first recognize that they are experiencing gender incongruence, but the ages I think are younger than people might predict from the general public. I've heard many social psychologists say that gender differences start to arise around the age of 2 or 3, and that there is some evidence to support this idea in these data. You can actually see the sort of the modal distribution there. A lot of people report first experiencing or feeling that their gender doesn't fit their identity or what they were assigned at birth around the age of 2 or 3. But if you look at just the main mean overall, and I mean, like, again, I wouldn't note the modal distribution here. I think it's actually very important. But there are polls here. But nevertheless, if you look at the mean, you'll see that most people can have recognized that they are incongruent with their assigned gender at the age of 6 to 9, which would have been be typically before the onset of puberty. Which, again, just when I'm thinking of how best to perform gender affirming care, it just the biology suggests to me that, I mean, like, it would make sense to start a lot of this right really sort of time locked to the onset of puberty, especially if the patients can determine pretty consistently that they are incongruent at an early age. And then here in the green, you can see the age of them coming out as transgender or not confirming. This almost always happens during puberty. Rarely does it happen before puberty, which is, I think again, noteworthy. You could theoretically identify people that will come out theoretically based off of questionnaires that might get at gender identity questions beforehand. How perfectly correlated those are, I don't know. It seems like it would be important to explore further. And then age here at your final sort of path of transition, that would typically involve medical or surgical transitioning. And here you can see that, of course, that is occurring younger in the YPY group, which again officially begin their transitioning at the medical and surgical level well before the age of 15, whereas 15 and older is grouped in the OPY group. But this is also the a big slide that I wanted to show you is in terms of like why someone might, it would certainly be more cautious, right, to try to intervene later. At the very least, it's more palatable, I think, to someone that isn't completely on board with gender affirming care to tell them that none of the hormone blockers would occur until after the age of 15 or 16, but with the idea that hormones can organize the neuroendocrine system, there might be quite a bit of reason that such intervention, like puberty blockers or hormones themselves, should be given earlier in puberty. And here are some of the differences that you see if gender affirming care starts before the age of 15 or after the age of 15. Those that receive gender affirming care are younger onset reported significantly less incidence of depression, significantly less incidence of self-harm, and significantly fewer incidents of suicidal ideation, which is what history of SI is, or suicide attempts. So, in summary from this study, of 300 youth, 116 started to transition or started to undergo gender affirming care under the age of 15, and over 184 patients were in the OPY group. And you saw significantly less incidents of depression, self-harm, suicide, and the need for psychoactive medications in those that begin the gender affirming care before the age of 15, which I think makes a lot of sense from the perspective that the neuroendocrine system is still being organized by hormones at that point in time. Most certainly, you can give testosterone well after the system has been organized. And I mean, you will see increases in muscle mass. You will see changes in, for example, an Adam's apple and some, external secondary, or secondary sexual characteristics. You can see the deepening of the voice a little bit, of course. But you do, I think, lose out a little bit on the magnitude of what the effects could be, and it's possible that some of these treatment windows will shift to younger ages, possibly as the medicine evolves, as the treatment approach evolves, and as the legal system evolves. I now live in the state of Maine, and we're debating one of these bills right now. And it is in ours that you could only have the hormonal interventions occur at the age of 16, I believe, is the age cutoff. And they don't mention puberty blockers at all in there. So it is not clear to me if a doctor would be protected from giving a puberty blocker to somebody before the onset of puberty. It boggles my mind as to why someone would give a puberty blocker after the puberty is ended. So maybe that's just why they don't even bring it up in this particular bill. But puberty blockers are certainly an important consideration here in the whole grand scheme of things. But then still, if you're only giving estrogen or testosterone, and I mean, for all we know, there could be more to it. There most certainly is probably more to it than just those two hormones here. I think we'll have probably better tailored cocktails of hormones for gender affirming care in the future. But and maybe they'll even change a little bit at different ages as one develops. I don't know. But whether or not that should occur before the age of 16, I think is certainly a worthy question. I don't have an answer to that question. It's not my intent to give you an answer to that question. It's certainly just something I want you to think about, though. In general, if hormones organize in your endocrine system in developmentally sensitive windows, treatment after organization has occurred might be limited to secondary sexual characteristics, etc., rather than more profound changes that might confirm one's true identity. I also think of the five ARD patients whose testosterone increases in puberty, usually, toward the onset of puberty, it would seem, transition to male. I mean, you even see the emergence of a penis, the testicles descend. It is, I think, noteworthy that, I mean, there are some subtle differences here to those in comparison to those that did not uh, uh, receive some hormones during fetal even sexual differentiation, but they certainly transition pretty drastically, as you can see from that image that we looked at in the one case study in this PowerPoint presentation. And yeah, I think it certainly is a proof of concept that, I mean, like, this can occur and the effects can be very uh, normal. I mean, there's a biological condition where this does occur normally, so it might not be that strange even to start administering the hormone therapy at the onset of puberty rather than after puberty has ended. Which is what I guess you would be limited to if the rule is that you could not give these drugs before the age of 16. Now, that being said, I certainly acknowledge that giving neuroendocrine altering chemicals to 8 to 12-year-olds when pubertal organization would begin remains very controversial. This is why I think in states like where I am now, the bills that are not even passed yet that are being proposed tend to restrict chemical treatment to the age of 15 or 16, where in this, there's a neuroscientific reason for this too, right? A lot of it involves the frontal cortex. So the frontal cortex isn't fully developed, really, probably until the age of 30, to be quite honest. The frontal cortex and a lot of the white matter changes that you see in the transition from adolescence to adulthood. While puberty seems to be getting earlier in America, the age as early as 8 in some cases. I don't think that adolescence is ending earlier. If anything, it seems to be sort of the state of arrested development, where we are developing much longer, even until the age of 30 or so, um, before we're fully baked in terms of a frontal cortical perspective. So, if you're uh, right, so it's there's a lot of gray area here. I mean, like, when is the right age to have your first alcoholic drink? At 21, apparently. What age is it appropriate to have sex? That varies a little bit depending on the state. It tends to range from 15 to 18, I believe. When are you allowed to go fight in a war? Sign up to do that? When are you allowed to vote in an election? When are you? When do you have enough of a frontal cortex to know, what your gender identity should be, and how well is that correlated to the numbers that you see of people reporting that they knew their gender identity was incongruent at the age of 2 or 3? Um, and at what age should puberty blockers begin being administered? Uh, you know, Possibly at the onset of puberty. And when should hormone therapy begin? Should it begin, throughout this neuroendocrine organization period, or at least the ends of it that occur during puberty? It's even possible one day, we'll have better markers for this, and you could even do stuff much even earlier in as an intervention. Who knows what the future will hold? But all of this is just to say that, I mean, it is a controversial subject. I acknowledge that it's a controversial subject. I'm not telling you what you should or shouldn't believe. I'm just giving you some things to consider about gender affirming care. And, I look forward to some of your thoughts on this subject too. I simply would like you to think about it and some of the complexities and nuances involved.